Welcome to week 2 of the evaluation and treatment of auditory processing disorders. During this week, we're going to touch on the characteristics and case history of auditory processing disorders. The first thing we want to talk about is when you look at the characteristics of auditory processing, the behaviors that are listed consistent with the disorder could be due to a number of different etiologies. So, students that are children that have autism, learning disability, attention deficit, a language problem, psychological issues can also demonstrate difficulty with following directions, poor focus and background noise, difficulty with academics. But one of the key characteristics of auditory processing versus the other potential etiologies is that we need to focus what behaviors are related to auditory only. So, for example, if you look at the difference between attention deficit and auditory processing, attention deficit children will be distracted in a variety of different situations. If there's smells, sights, sounds, they're going to be, could be squirmy, unfocused, fidgety, impulsive, where children with auditory processing are only going to be unfocused and squirmy when there's background noise because they don't hear well in background noise, versus attention deficit students not being able to focus because the noise is a distraction. So the behavior looks the same, but it's due to two totally different reasons. So a lot of what is done when you look at trying to triage auditory processing evaluations is say, or ask questions about what the student does in background noise versus quiet, or in auditory situations versus not. And so that's part of what you have to look at this list. So following long instructions or following multi-step directions also has a lot to do with how the directions are given. So if you have a student with attention deficit, they are going to have poor short-term auditory memory. It goes hand in hand. So they may be able to understand the meaning of an instruction, but if you give the instruction too long, they're not going to be able to remember it, and therefore they're not going to follow the instruction. Where the auditory processing student is going to mishear the information. So they may, if you say, go pet the cat, they may look at you funny because they thought you said catch. So they're not going to follow the instruction, but it's because they misheard it, not because they couldn't remember it. The other thing we need to always consider is when adults report these behaviors in children, we also need to make sure that the adults are giving appropriate auditory instructions. So when I do a lot of training with school-based personnel, I talk about the general auditory memory skills that are consistent with normal development. So a 6 to 7-year-old can only remember a sentence that is 7 to 8 words long, and those are words that they already know. So if you have a kindergarten teacher that's giving a 3-sentence long instruction, the majority of her students are not going to be able to follow those instructions. And it's not because they have auditory processing or attention deficit. It's because at that age, normal development says they shouldn't be able to remember that many instructions. So we also have to be careful that we're cognizant of the instructions that we're giving and that we're not overtaxing what is a normal developmental system. Children with auditory processing may be part of why students have difficulty learning or developing articulation sounds. So we all know that there are normal articulation errors that students have, but if they're in good intervention and they're not making progress, I often caution speech pathologists to do a little bottom-up auditory discrim screening. Because if you think about our congenitally hard of hearing children, we know that typically 20 years ago, they did not speak clearly because they couldn't hear consonants. Now with students and babies that get cochlear implants, their speech is so much clearer because they have access to that auditory information. So if you have a student that you know that has articulation errors that are not improving, certainly we want to make sure that it's not due to a bottom-up auditory closure issue or auditory discrimination issue. And then, as I mentioned in the last week, 60% of the students with auditory processing have a delay in the development of their auditory system, which means that it will continue to improve through age 12. Now, the goal is that we move that time frame up and improve the auditory function faster, because we don't want to wait until age 12 or 6th grade. But it makes sense if this is a congenital delay, that as they have been developing their auditory system that is behind, that it may impact their language development. So often you'll see literature that says 50 to 70% of children with a language impairment have auditory processing deficits. And what I caution people is that does not mean currently. So if you have a 7 or 8-year-old with a language delay, language disorder, their auditory processing skills may be okay now, but when they were 3 or 4, they could have been significantly deficit, and it's taken till 7 for them to catch up. So again, we don't know that because we can't test younger children. But when you have a student with delayed language development, we want to make sure that we're not missing a bottom-up problem. Because if you're a speech pathologist and you're working on top-down language and you're not getting anywhere and you're not seeing any improvement, it could be because there's a clarity issue. And then when you talk about the history of chronic otitis media, that is just a difficult topic to discuss for a number of reasons. The first issue is on parent report. That, parents, depending on if it's their first or their 5th child, may report lots of ear infections or none, not because they're being dishonest, but because of their perception. Secondly, they may have difficulty receiving treatment for ear infections. I do a lot of hearing tests on 2-year-olds that are in our early intervention First Steps program and that are going into speech and language therapy. And there are so many times where I will see a child with a red ear, abnormal hearing test, flat tympanograms. I send the family to the doctor, and the doctor says come back in 4 to 6 weeks. Because if the child is not symptomatic, meaning they're not in pain or they're not feverish, the doctor will not treat them with antibiotics. So a parent may do their best diligence to get an infection treated, but it's not being treated because of the conservative nature of antibiotics and ear infections. So we have a low documentation of treatment for chronic otitis media. That also does not include any student that has uninfected fluid in their ears or congestion. And those of you that may work with young students and academics know that there are so many children out there with allergies and congestion, and we have to think that that affects the clarity of their signal. Even if it's a slight hearing loss or what I call a little bit underwater, that signal that the brain is processing is very different than when the ears are clear. And if you go back and forth, just like an adult that's going to wear their hearing aids one day and not the other, it takes the brain longer to process with those different inputs. So the literature saying that the incidence of otitis media and auditory processing and language disorders is difficult to quantify is true, just because of the difficulty with trying to quantify or get accurate data on otitis media, whether it's diagnosed or treated. And then another classic behavior of students that have temporal processing is difficulty understanding rapid speakers. So if you have a student or a teacher with a dialect or an accent, temporal processing deficits affect a student's ability to hear what we call prosodic natures of speech, which just means inflection, pitch changes. So if someone's asking a question or being sarcastic or humorous or ironic and the tone of their voice changes, they don't hear that. So certainly if a teacher or an adult has an accent or dialect, it's going to be more difficult for that student to hear. And that's why typically in older grades, specifically college students, if they still have peripheral hearing loss or auditory processing, then we want to avoid foreign TAs as much as possible because it's more difficult for them to understand. So these are sort of behaviors seen with auditory processing, but I also wanted to flesh out some differences in terms of other potential etiologies that may be causing this. But a lot of the differential diagnosis or triage has to do with asking questions beyond a report of they don't follow multi-step directions, they don't listen well. And I often ask, well, what are they doing when they're not listening? Are they appearing to focus? Are they fidgeting? Are they talking back? Are they being impulsive in their conversation? A lot of that's going to give you better insight into what the next step should be, possibly other than auditory processing. So when you look at case history or medical history that may be consistent with auditory processing, jaundice is a relatively new one in the last 10 years. And I'm talking about jaundice that is significant enough for a blood transfusion, not just light therapy. There's research that indicates that the high bilirubin can affect the cochlear nucleus going to the brainstem. And so that can affect some higher level auditory processing issues. And then obvious issues like lack of oxygen or head trauma can certainly affect auditory processing skills. And medications, not in terms of causing auditory processing, but you also have to consider if a student has difficulty focusing and they're on seizure medication causes students and adults to be fuzzy and not focused. And so we want to look at all of that when we are kind of trying to differentially diagnose for auditory processing. Could there be other contributing factors with that? And certainly other diagnoses such as attention deficit, psychological mood disorders, depression, anxiety, learning disabilities, language problems. And then a lot of occupational therapists work with students with sensory integration difficulties. And sound sensitivity or the inability to tolerate loud sounds is sometimes recorded as a common complaint in students and adults with auditory processing. And one of the cautions is that we need to make sure that that sound sensitivity is not part of a bigger sensory integration problem. So when on my case history, parents report or say, yes, the child does not tolerate loud sounds, I also follow up and say, do they have any difficulty with food textures? Not that they're a picky eater, but do they not eat certain foods because they're crunchy or soft or hot or cold? When they were toddlers and early elementary, would they not wear socks or didn't like blankets or wouldn't wear certain clothes because of the texture? Did they have extreme sensitivity to light? So you want to look at kind of a broader sensory integration disorder, which is the child cannot control their body's response to the environment. And certainly sound sensitivity can be part of that. We also know that students that have a history of otitis media tend to have sound sensitivity once their ears are clear, whether they get tubes or they are treated for ear infections, that if they are chronically a little underwater and then suddenly the signal is clear, things sound so much louder, and there's some initial emotional reaction to that you have to get through and learn to tolerate. So just because a high tolerance or inability to tolerate loud sounds can be consistent with auditory processing, we also want to probe for any further sensory integration problems. And then social skill difficulties are typically because they misinterpret what's being said. So on the playground, they don't understand why everyone's laughing because they thought Bobby was being mean. They didn't hear tone changes in their voice, but they are in there. They're trying, they're communicating, they're playing, versus a child on the spectrum that may not be interacting, that is more isolated. Now, the result can be that after a few times of trying to verbally interact, if they're struggling, they may not interact or initiate playtime, but they typically are not socially awkward. They just misinterpret sometimes auditory information that's being said. In addition, children with auditory processing are typically not behavior problems. So they are not going to be in the principal's office. They're typically sitting in the classroom quietly listening, but information is not clear. So again, they may be a little fidgety in background noise, but they're not behavior problems. And so that's also one thing that we typically don't see. So some case history information that is not consistent with auditory processing is important to talk about, because if you have that reported behavior that the child is in the principal's office or getting in trouble, that may be a reason to say it's not auditory processing. So we've talked about some of the issues that could be consistent and others that may not be. And sometimes that's part of the case history. So the impact of auditory processing certainly can affect communication and academics. And the next slide goes through some specifics in terms of the impact of just general communication skills and academics.